the Saginaw Valley State University. At this time, we ask that you please silence your cell phones. We also ask that you take a moment to note all emergency exits, both in front of and behind you. Thank you, and enjoy today's event.
Good morning, guys. I'm Sam, graduated in 2015. Nice to see everyone here today. And like I said, it's been fun. I'm a clinician at My Michigan Health. I have been since I graduated with my master's, and I've never looked back. And so, like I said, today we're going to talk about being a generalist. And we'll get into it in a little bit. This is going to be kind of an unconventional format. This isn't a State of the Union address. I'm not going to be representing any kind of professional organization, but I'm going to be talking about the field of occupational therapy, and hopefully that some of it sticks with you today. And I realize we got a cool room of people. We got a lot of students in the room. Some are maybe not even graduate students yet. Some are graduate students, and some are about to start the level 2 fieldworks. Some have been clinicians for a year, and some have been clinicians for probably 20 or 40 years. And so when I talk to you today, clinicians of 40 years, don't think I'm trying to teach you anything new because you've been through it all. And but maybe I can learn something from you today. And certainly, when we go to the breakout sessions later, we're going to learn a lot of specific information in those breakout sessions. But my talk today is about being a generalist and doing the most good. And that's the title of the presentation. First, the fact that you're here right now makes you special. You probably could have figured out something else to do today. So for some of you, maybe this was mandatory, or you helped put on this conference. But you probably could have skipped today. You probably could have went to work and saved a vacation day, or you probably could have saw that it was going to be 80 degrees out today, and you probably could have, went out for ice cream after work. But you chose to come to the SOTA conference because you want to get some credit, you want to learn, you want to meet some of your friends that you graduated with and some new faces. And so thanks for coming today because the reason we're here is to build the profession and build our skills. And I appreciate that. The overarching theme here is a term called beneficence. And I remember at Delta College in the planetarium, I took a medical ethics class. And I'm pretty sure we all had to take some kind of class like that. And there was one medical ethic that seemed like it was more important than the rest of them to me, and that was beneficence. And if you Google it really quick, it'll tell you that it's the principle of promoting good. So non-maleficence would be not doing bad things, but beneficence would be doing good things and promoting those good things. That's a picture of Jimmy Carter. He was the president of the United States. And he had this quote that he said that my faith demands that I do whatever I can, wherever I can, whenever I can, for as long as I can, with whatever I have to try to make a difference. That's really worrying, but I think he meant it to be worrying on purpose because he's basically saying, there's nothing that I can't do. I have all these resources to do good. That's probably why he became a president, and that's probably why he was a good philanthropist for the future. Here he's pictured working for Habitat for Humanity, something he's done until really recently, in his 90s. And he's still alive today. I think he's on hospice now, but he's been working on these houses into his 90s, and he just doesn't stop. So beneficence, doing the most good. Let's keep that in the forefront of our minds as we go forward. Everyone knows the saying. They say, oh yeah, jack of all trades, master of none. And we use that saying to self-deprecate sometimes and kind of reflect on how we know a lot of stuff. Like, well, we don't really sure. Sometimes we use it in home improvement. Like, yeah, I can fix the sink or whatever, but don't ask me to install a new bath. It's kind of a nice fallback phrase. And we feel good about being the jack of all trades. But as I heard that phrase and I was thinking, occupational therapists are kind of like the masters of everything. I'm not trying to brag for our profession too much, but we are really in charge of everything that a person is involved with. Anything that's really important to them, anything they really do, that doesn't really go for any other profession. That is our profession. So we get the opportunity to be the master of all. We should know, or we could know, everything there is to know about this person's life. And so maybe we should start thinking about ourselves as a master of all. So I'm going to present a scenario. This is an analogy. And this is going to kind of guide us going forward in the talk today. Pretend your car is broken, or a customer's car is broken. It won't really run right anymore. And so the customer takes the car into a mechanic shop. It's a local shop, and they say, okay, my car is broken. The mechanic's been working there for 10 years, and he knows how to work on a lot of cars. And he says, well, I'm afraid that your piston's bad in your car. The piston is ruined. It's been 200,000 miles, and you need an engine rebuild. You need at least a new piston or something in there. And then they say, okay, let's go ahead and let's do that because I got to have a car. But then the mechanic realizes he's got a small problem. He says, well, this piston is on a Ford F-150, and I've only worked on Silverados my whole career. I really don't know how to repair a Ford F-150. I only know Silverados. Well, more than likely that shop, to stay afloat, is going to have to work on something other than just Silverados for the next 30 years. This mechanic will at some point have to call somebody and ask them, how do I take apart this Ford F-150? How do I replace this piston? Because otherwise, this shop's not going to be in business anymore. That customer is going to be without a car, and that mechanic isn't going to feel too good about him or herself. So he or she has to figure out a way to put this engine back together. And we do that through continuing education. We're here today at the SOTA conference, and we get a chance to learn new things or refresh our minds on things that we haven't heard in a while and actually boost our skills. It doesn't have to sound like a drag to do continuing education. I think sometimes the name gets a bad sound to it, but it can be fun. You're going to find something that you don't know about in your career, and you're going to be a little scared, like that mechanic who really didn't know how to work on that motor. And you're going to have to find something to help you through it. So I'm going to talk about three main things today before I let you go. These are some things that help me, and maybe they can help you too. There's a lot of websites out there. They're made by third parties like MedBridge, and they're in charge of making instructional videos and courses and home exercise programs that you can learn new things about. They have knowledge tracks, and you can actually get certified in certain things through these online websites. LSVT Big has been a big thing for me to learn how to do that and do that with my clients and get certified in that. That actually helped me in a big way that we're going to talk about later. And then through SOTA, they have things called micro-credentials where you can learn and earn digital badges about certain things. So through the use of all of these entities, I was able to kind of start building my skills and feel a little bit more confident. All of a sudden, when someone brought in a Ford F-150, I didn't get all scared anymore. I figured out a way to kind of help this client. Because if you don't, and you pass it to someone else, there's a strong chance that it might never happen. That car might go in the junkyard, and they might get a new one. So ease up on the content. This is the keynote speech, right? It's really not supposed to be about a whole lot of content. Well, I can't help it. So that's what I'm going to talk about today. And I think if some of this sticks, it might help somebody. I'll keep it brief, though. First of all, I want to start talking about some things that everyone's going to see. Clinicians who have worked a long time, you've seen this before. You've seen this client who comes in, and they're in a lot of pain. Students, you might be thinking about the diagnosis. Why is the client in pain still? The MRI was fine. The CT scan was fine. Why is this client still in pain? There's going to be a lot of factors that influence this client's pain, and we're going to talk about it next. There's going to be psychosocial factors that exacerbate their pain. They might develop chronic pain, and that in itself might be a factor that keeps building on itself. But for some reason, no one knows why this client keeps hurting. That's up to us to figure out. Luckily, there's people who are smarter than me and have devoted their whole lives to studying certain things. Dr. Adrian Lowe is a physical therapist, and he holds a PhD in pain neuroscience. And so he developed a whole program to help treat people with chronic pain and help clients understand the reason they're in pain. And a big reason they are is because of things called yellow flags. Some of the things on this screen are making people's pain worse and heightening their anxiety. Things like grief or trauma. Maybe they don't have a paycheck anymore and they can't really buy the food they need for their house. They're having marital or relationship problems. I put failed treatments on here twice by mistake, but it really could be there on purpose because failed treatments are a big reason people are in pain. They could have failed treatments in physical therapy. You could have had a failed injection that doesn't work anymore. You could have had a treatment. You could have had acupuncture, dry needling. It didn't work, and now I feel even worse about myself, and now I'm in a lot of pain. You could have some fear, and that fear could be eating into your pain. Or job issues. Maybe you don't know if you're going to have a job the next month, and that's really affecting your pain. So, I drew this picture. It's a bad picture because it's not really clear. But I drew it anyway because it's the only way I knew how to explain what Dr. Adrian Lowe has been devoting his whole life to. People are in pain for bad reasons now. Usually this reason is they've had an injury and that traumatized their alarm system in their body. Your body has a sophisticated alarm system it uses to warn you to get out of danger. And sometimes that alarm system stays on high alert. So here with the normal activities wave right there, that is what your nervous system is like during the activation of normal activities. And your normal pain threshold used to be way up there. You used to be able to take a lot to get through the day. You could really finish any kind of job and you get the job done. But ever since you tweaked your back and you also lost your job and your wife left you and you don't have any money anymore and you lost someone really close to you, all of a sudden you're really stressed out and that new pain threshold is at the orange line. That's the unfortunate new pain threshold. So now, whenever we get a stimulus to excite that pain, it gets worse. All of a sudden it takes over our lives and we present with a lot more pain. There's two terms here, allodynia and hyperalgesia. Your patients are going to present to you in pain already when they enter the clinic. They might never have had an injury, but they're in pain. When you have pain for no apparent reason, and there's no biomechanical reason to explain it, we call it allodynia. So, pain for no reason. Let's say I have a back problem and I just turn a little bit to the right. That normally wouldn't hurt a whole lot, but all of a sudden I'm really stressed out. Now it hurts a lot. And that's called hyperalgesia. That really affects me. If we can understand these two ideas and how they affect us and how they affect our patients, we can start driving this pain down. So this red line here is when more strenuous activities are listed, it's too much for them to handle and they have a really bad response to that pain. So what do we do about it? We got to figure out something to do. We have to install some kind of exercise program. Do we go right at the tissue that hurts? Do we try to stretch it a lot? Well, that could be an issue. But Dr. Adrian Lowe calls it tease it, touch it, nudge it. So next time you have a client in pain and they're wondering what to do, we have to tease the pain, touch the pain, and nudge the pain. We're going to do it easy. We're not going to scare them. We're going to do an occupation. We're going to do something they enjoy. We're going to help them learn how to do that thing despite the pain. We're going to celebrate when they're able to do that thing a little bit better because they were able to tease that pain threshold. And maybe they had to ice it later, that's fine. But the one thing we're also going to do is we're going to elevate their heart rate. We're going to go for 120 beats per minute for the heart rate. We're going to try to do that 20 minutes a day. We're going to increase the blood flow in their tissues, and we're going to try to improve the endorphin level in their bodies to kind of fight this pain, just like an athlete would. And we're going to push that pain threshold back. We're going to better understand their pain, and they're going to be more appreciative of it. That's pain neuroscience in a nutshell. And that will really help you with your clients, being a generalist. The next thing we're going to talk about here is driving and community mobility. This whole morning is about being a generalist here. And as I began my career, just a little bit about me, a little bit more. I started my career as a per diem therapist. That meant that I just filled in wherever people would have me. And I was really appreciative of it. I would work in inpatient mental health. That was a really learning experience. I would work in outpatient hands, outpatient neuro. I would work in peds. I would work on acute care floors. And everyone really liked the fact that I was covering for them when they go on vacation. And I kind of felt really valuable. I felt, man, that's a nice feeling. And they were just happy that I covered for them, really. They cut me a little slack. It may have not been what they did, because they've been doing it for 20 years. They have a hand certification, or they have all kinds of certifications, but they were just happy that I covered for them. I had a lot of slack. And they were able to teach me a lot of stuff in that first year. The opportunity came for me to become a pelvic floor therapist. And I thought, well, this could be my shot. I could be a full-time therapist now with my company, and I could be a pelvic floor therapist. And I thought, yeah, that kind of sounds nice, because that's a big deal for people. That could really affect their day. I mean, you think about, that's a really personal issue. I could be their best friend. I could really help them. I thought, I think I'm going to do it. I think I'm going to do it. And I talked to my boss, who was presenting me with this opportunity, and she said, you know, you've been great around here. You've been like an Andrew Romine for us. And for those of you who don't watch the Tigers all the time, about 10 years ago, Andrew Romine was this player, and he was an okay baseball player. And but you could, if the game was out of hand, you could throw him in, and he could pitch for you. He was a position player. He could play catcher. You could play him at third base. You could put him in the outfield. It really didn't matter, and people just thought it was kind of neat that Andrew Romine was out there, and he was pretty good at everything. But for some reason, and it was a compliment. And but for some reason, when I heard that, I thought, well, that's not Justin Verlander, though. Or it's not Miguel Cabrera. Andrew Romine's not on SportsCenter. And I don't feel very special. But that was a compliment. I thought, that's kind of neat. And I thought, okay, well, I could be Andrew Romine. That sounds nice. I was a generalist. The opportunity came for me to be an outpatient neurological therapist, and I thought, you know, that sounds really great. I think I'm going to do that. We'll talk about more of that in a little bit. So I became an outpatient neurological therapist, and lo and behold, that was a lot more than just people with strokes. It was a lot more than people with Parkinson's or spinal cord injuries or MS. All of a sudden, I was getting these referrals for people who had a diagnosis, or it wasn't a really good diagnosis, or the diagnosis didn't really make sense. I was getting a lot of people who didn't really fit a category. And of course, I would get a lot of strokes, people who survived a stroke, a CVA. And they would come to me and they would say, hey, I heard that you're the person who's going to tell me whether or not I can drive. And I had just got done playing with the pediatric unit. I really haven't thought about driving since school. And I thought, well, this person looks kind of dangerous down the road. That doesn't seem really right to me. But I didn't really know the answer to the question. And so I panicked. And I felt like saying, well, you should probably go ask your doctor. It sounds like something your doctor's in charge of, I don't really know. But it took me a few times to figure out that the doctor only really knows them pretty superficially. They might have only seen them for 10 minutes every few months or every year. The doctor doesn't really know them like I do. I had the opportunity to see these clients 2 hours a week for weeks and months. I was the only person in the world that really knew what they were dealing with. If not me, who was going to interrupt this person from driving on the road? The doctor didn't feel comfortable with talking to him about it. And so I thought, this might be an opportunity for me to learn a little bit more. I'm a generalist. I'm Andrew Romine. I can play first base. They need me to play first base right now. I can figure this out. And so I went on SOTA and I took a bunch of little classes about how to do it. And it was pretty easy. And I learned a lot. And the one thing I want to share with you today is this model here. It's a stoplight model. It kind of reminds you of driving, doesn't it? Because it's good visual imagery. But you can start to think about your clients in these 3 phases. You got the green phase. This is the person who survived a stroke and they're doing pretty well. You really can't tell they had a stroke anymore. Their symptoms kind of resolved after a few weeks. Their hemiplegia is kind of gone now. They had a little brain fog to begin with, but that's really clearing up, and their vision never really took a hit. So they should be okay, but you might want to work on those sub-skills a little bit more before they feel comfortable driving again. We go to the yellow light. This is your group of people who had some significant performance pattern loss. They have hemiparesis. They've got visual problems. They've got processing problems. They can't do 2 things at once, which, by the way, is a really hard thing to do, and it requires a lot of work while driving. And then you got the people in the red category. These are people who maybe are getting older and they're getting dementia, or maybe they are having some age-related changes that they really aren't going to recover from, and it's time to start thinking about driving cessation or stopping driving. I was a generalist, and this little model really cleared things up for me. The next time someone asks you if they can drive, if you're not a driving rehab specialist, like I am also not, you might want to look to this model first. And you might think, well, okay, that's great, but I really don't know how to answer that question yet. Well, people have devoted their whole life to answering that problem, so I don't have to. I'm a generalist. So I know that I can look to this resource that's titled the Generalist Resource to Integrate Driving. It was so neat when I found that, because I thought, hey, I'm a generalist, I can do this. And look, it's full of all kinds of things you already know about. There's the trail making test. You can Google that in 5 seconds and the PDF comes up. You can print that off. There's the amps, the clock drawing, there's the MOCA. You can print off a lot of these things off the internet. You could do a quick screen to see if there's strength's there, if their coordination's there. Is there sensation there? How are their cognitive skills? Can they do 2 things at once? Are they managing their medications at home okay? Can they make a meal for themselves? These are all questions that you already have the answer to because you're their occupational therapist and you know all about the person already. And if you don't, you're entitled to ask them about it. It's really neat. You get the privilege of talking to these people about these things. And as we go down the line, you start to put people in a category and you start to evaluate whether or not they're ready to drive. And guess what? You can pass the buck to a driving rehab specialist eventually if you think that they're ready for that step. You, the generalist, can work on those performance patterns and skills until you think they're ready for the driving rehab specialist. And then you turn it over to the person who does such a great job, a better job than you, at evaluating their skills at driving. So anyway, that's driving. And I didn't know anything about it until I started looking it up. Another thing that happened to me was I was fortunate because when I took this role as the outpatient neurological therapist, the outgoing therapist was able to stick around for a little bit and teach me some stuff. And I don't think that happens very often. I was pretty fortunate to receive that. And I remember we were going over the caseload for the day, and she said to me really quick, "Oh yeah, and the next patient has Parkinson's. You know what that looks like, don't you?" And I immediately thought, "Oh yeah, I think I do. Like Michael J. Fox had Parkinson's. That's right. I remember him." But then I thought, well, I don't really know much more. I know I learned it in school probably, but I forgot everything, and I don't really know. But yes, I do know. I'm sure I can learn, I didn't tell her all that. I knew I could figure it out. But that's why you ask questions. There's people who devote their whole lives to treating this. And so with a little bit of interest, I was able to take some LSVT big training, get certified in that, and learn a lot more about it. Now I like to speak to people through Michigan Parkinson's Foundation and give educational seminars. I like to work with Rocksteady Boxing on getting people alternative resources to work on their performance skills and patterns. And so this was a gateway to everything else. All of a sudden, I felt a little more confident about treating this, and I actually felt like an expert. I felt like a mechanic who actually knew how to take this motor apart. So be prepared, like Mufasa said. No, it wasn't Mufasa, it was Scar. Be prepared. Or don't be, because I wasn't. You're going to get clients who have a diagnosis, and that diagnosis doesn't really make sense sometimes. Or maybe the patient's demonstrating some symptoms that aren't really part of that diagnosis. It doesn't really fit. Or maybe this person just needs help despite their diagnosis not making any sense. Now, if only there was an occupational therapist around to help learn the client and suggest something they could benefit from, we could be that person. You could pass this client on. You could say, I don't really treat that diagnosis. You better send them away. There's probably another clinic out there that's good at treating them. But you know what? The system's kind of broken. And even though there might be a better therapist out there than you at treating this, that's had more experience, you could be the hero for this person if you give it a chance. And if you give it a chance and it doesn't work out, you can pass them on then. You can talk to someone about it. So what do? You get this client. You're really not sure how it's going to go. You're a little scared about it. You want to do your job. You don't want to be unethical. You just don't want to start throwing the kitchen sink at it because you feel like you should. What do? No one really prepared me for this. No one's answering my emails, darn it. I can't find anything on Google to help me. I don't want the kid's mom to think I'm weird and I don't know what I'm doing. I don't want the person to think I'm a noob or something or I've never seen this before. What do? Well, just start seeing the client. That usually works. And you can use what you have already. Everyone in this room has a therapeutic use of self. They have the ability to use their body and their mind as a tool to help people feel better. Everyone in this room has the ability to make someone feel better. When you come to therapy, if you're a client, do you really think that the patient wants to go on an all-out bodybuilding frenzy? Or do you think they really want to go get some sort of back manipulation by some kind of high-tech machine? Maybe, but they want to feel better. They're coming to therapy because they want to feel better. Doctor said therapy make you feel better. So let's make that environment a healing environment. Let's make it a positive environment. Let's start asking thoughtful questions. You can be friendly, You don't have to be their best friend, but you can be super friendly. And let's follow up with those responses to those questions. Use some eye contact and let them know you're listening to them. If they don't like your eye contact, you can look away. Some people don't like it. You're documenting, you're getting your notes done, but the person starts crying and their husband died 3 days ago. Should you keep typing? Probably not. You should probably talk to them. But turn your laptop away. If it's appropriate, you can touch their hand. If it's appropriate, you can guide them into the clinic with your hand. Some people like that touch. They're coming to you. They're not doing telehealth right now, they're coming to you. You can relate to them. You can say, hey, my back hurt too. Or, yeah, I struggle with this too. Or, yeah, I get confused sometimes too, especially when I get flustered. Don't be afraid to share what works for you. But don't reduce the client's problems either. Don't just say, hey, this worked for me, so it should work for you. Just because it works for you doesn't mean it won't work for them. And just be there. Let them know we're going to figure this out. Not you. I'm sure you'll figure it out. I am going to figure this out with you. We're going to figure this out. So a good example is a client I had recently. He was a young male client. He was like 12 years old. And the diagnosis said sensory disorder. And I'm a neurotherapist, so that kind of seemed like the place to go was to send him to the neuro clinic. And so I evaluated this client, and I started asking some questions to him and his dad, and the dad said, Well, me and his mother split up about a year ago, and ever since then, he's been having a lot of some depression. He's arguing with his brother a lot. He's not really participating in school a whole lot. Not many friends. It seems like he just has no confidence in himself. The dad was telling me this right in front of the kid. This was a big deal. And he was here for sensory problems. And I said, so I'm going to give you this sensory profile thing. I'm going to have you fill it out. He can spin around. He doesn't have aversion to any foods. He plays like flag football sometimes. He really doesn't have a problem getting touched or anything like that. And so I thought, well, this is weird. I don't know what to do. Do I just stick his hands in these rice bins for a long time, and maybe that'll maybe he won't be so depressed anymore? I thought, I don't really know what to do. But I figured I could always discharge this client if I'm not doing anything. I could discharge him. But I could discharge him now. I could say, sir, it doesn't seem like a sensory problem to me. I don't think we can figure it out. You might want to just, I don't know, maybe some medication or something. But I said, no, it could be. I said, let's get to learn each other. Let's go to we'll start spending some time together. Come in next week and we'll start to test some things. We'll figure it out. So what do we do? Anything he wants to do. It's occupational therapy, right? And I went back to my desk later, and I was talking to my coworker, and I said, I don't know what I'm going to do with this, because I don't want to just do random things. It just doesn't seem right to do random things with somebody and hope they get better. And he said, well, yeah, it does seem like they need a life coach or something. And I thought, well, I don't even know what a life coach is, but I feel like I am one. I feel like I should be able to do that stuff. I know about life, and I know how life goes, and we learned about all that in school. We had a master's degree in it. And I feel like I know all that stuff. I didn't tell him all that in that moment, but I thought, dude, you just surrendered your superpower for a second. We have the ability to dive into this person's life and figure out everything about them and give them helpful techniques on how to overcome certain things. I was thinking about sticking his hands in some rice bins and use a conventional solution for an unconventional problem. And I stopped thinking about the occupational profile. So I said, what do we do? And I thought, okay, I'm an occupational therapist. Well, we should do some kind of occupation. I knew he liked playing flag football, and we'll figure out. He likes sports. He has a PS5. I understand that was a hard thing to acquire, and that must be important. So we'll talk about the PS5 a little bit. We started to do some occupations, and we re-engaged in the things that were important to him. All of a sudden, he's smiling. All of a sudden, his dad says, yeah, he looks forward to this every week. He asked me if it's an occupational therapy week. And I thought, well, that must be something good, and we can build on that. And I don't want to be the crutch forever, but I'm going to help you guys figure out something that works. Okay, but what do I really do? What do you really do? I don't know either, but I put together some things that I find valuable. This is Sam's Emergency Generalist Kit. These are the things that if you are going to do your first treatment with somebody, you evaluated them, and you really have no idea what you're going to do yet, because you were really busy last night and you're stressed out, and I forgot this patient was today and I don't have a plan yet. This is for you. The daily schedule is good. Let's do a daily schedule. That seems like a cop-out thing. A daily schedule? Yeah, we know. But this is huge. Go to Google. Print off one of those grids that says 7 a.m. to 10 p.m. Figure out more about this person's life. Figure out when they take their socks off. Figure out when they eat a snack after supper. When do they take their medications? Is it wearing off? Remember this thing we talked about, the occupational profile? We kind of profile somebody and figure out everything about them. You can do that with them. People like it. People love it. They're the center of attention. They feel like they're getting healed. You can sit down and say, I want to develop an occupational profile with you right now. Let's figure it out. Go to the whiteboard or the chalkboard, get out a piece of paper, and let's outline their rituals, their roles, their habits. Let's outline the things that are really important to them. What's their body doing? What are some of the barriers they have in their life? Let's outline it all and get it out in the open. This doesn't have to be something you keep to yourself in your laptop and that you hide from them. It's just between you and their doctor. This is part of the team, and they're part of the team with you. You can have a big discussion about it. And all of a sudden, this person knows that you're invested in them, and by the way you've talked to them through that hour, they understand that you know a lot about them already, and they've bought into you. Educate.
what an occupational profile is and teach them the importance of occupation. Introduce them to a guide to healthy living. You can make this up. You could Google how to live healthy and you could just start implementing some healthy things. If the person's stressed out and you really don't know what to do, you could try progressive muscle relaxation. You've probably heard of it before, but you just grab your smartphone and you take them to a room and say, we're going to try this new thing. You shut the lights off and you type in progressive muscle relaxation on YouTube really quick and you hit play. And you sit with them and you do it with them. And you help them understand their bodies and that they do have muscles that work. And that it really didn't hurt that bad once I started to breathe and once I stopped thinking about all my stressors. You can encourage them to journal because you know that expressing your own ideas helps you to understand those ideas and your own thoughts and feelings. And oh yeah, aerobic exercise, like Dr. Adrian Lowe says, we need to get some aerobic exercise to ramp up the nervous system and start healing these tissues. You could ask them, what's for supper? That's the go-to. I say, what's for supper? If you don't know what to say, just ask them what's for supper. Then the whole conversation will start. And if that doesn't work, you say, what's going on this weekend? That's a good one. Or the weather is a good one, although people get sick of the weather. But just talk to them. That'll lead to something else. Just get the ball rolling. This is something I started to do. I really couldn't keep my thoughts straight for a while, and so I thought I need a piece of paper. I don't want to put things in my iPhone anymore right now. I want to write it down. So I invented the pocket planner. This is a piece of paper that I stole from the break room, and it's cardstock, so it's really nice and thick. And I cut off the edges of it, and now it fits in my back pocket really nice. And I open it up, and I write down all the things I'm thinking and feeling. I write down my to-do list, things I'm grateful for that day. I write down some of my goals, and if I have ideas, I put them in this little light bulb section. That means ideas. And I had a client who was really having a tough time with attention and with keeping her thoughts straight and with short-term memory problems and long-term memory problems. And I said, hey, this is something I've been doing. She fell in love with it. I just give this to my clients all the time. I get out the scissor, I talk to them, I make them this little planner, and I said, I want you to bring that planner in next time, and let's try to talk about some of these things that you've been going through. That'll help you. The image next to it is something I made on Google Docs in about 10 minutes. It encourages the client to have a steady diet and consume water, practice mindfulness and spirituality, socialize in some form, and journal. Did they make their bed that day? Do you brush your teeth? Keep them on a schedule and get them to journal about it so you can be more aware of what's going on with them. All of these things are their occupations. And if you really don't know what to do, at least you can better understand some of what the client's doing. These are just some ideas. You might hate them, but think there's some value to them. You could do something else. This is just my idea. Oh, would this work? This is a pamphlet that we sent the clinic. It has all kinds of adaptive equipment in it. You could call the company and say, hey, I loved your pamphlet. Could you send like 20 more of them? And they will, because they think you're going to buy all their stuff. You get a box of these things to your clinic, and then you hand your client these pamphlets and say, this is what OT is all about. Do you think you can maybe do some of the stuff you want to do with the help of some of these things? Say, yeah, but I don't know how to order it from here. I said, well, just order on Amazon. We can do it together. Give me your phone. Let's order it right now. You can be their advocate. We can figure this out. But how do I bill for that? You said you were playing Mario Tennis on the N64 with your client. How do you bill for that? It seems like you're just kind of wasting time. Well, who cares? Who cares how you bill for it? Just kidding. I'm kidding. But I am kind of serious about it. It doesn't matter. We're going to figure it out. Look at this bullet point. If you were dying, let's say right now you started having incredible stomach pain and you have to go to the ER right now. You go to the ER. You're sitting in the emergency room. You're on the operating table and the doctor's about to do something. And they're going to make you feel better. What do you want them to be thinking? Do you want the doctor to be thinking about, how do I bill for this? Is this an incision, or am I just poking them or something? Or I don't know how to bill for this. Let's not do anything. That is the worst thing ever. Don't let how do I bill for this stop you from doing something that's going to help somebody. Let's remember the idea of beneficence and doing the most good. Do what you can, however you can, with whatever you can. And if you're performing occupational therapy, you will realize you are, and then you'll figure out a way to bill for it. There's going to be codes, and you're going to say, well, that kind of seemed like an ADL thing. I'm going to bill it as an ADL. That seems like neuromuscular reeducation to me. Let's bill it as that. Don't let billing be your first thought. Let's make that the second or third thought and think about how can I make this person's day better right away. You can do it. And if you have questions, you can ask somebody. Now, when I was writing this little PowerPoint, I did it on a Saturday, and I thought, man, I feel like I'm just like minimizing the importance of everyone with a certification. And I think that sounds so insulting because people have devoted their whole lives to become a certified hand therapist. I'm not, because I think it looks really hard. I don't know if I could do that. I'm not a driving rehab specialist. I'm not lymphedema certified. I'm LSVT big certified, but that only took like 16 hours, and I did it on the computer. I don't really have hardcore certifications. But when I get in trouble, I talk to people who do, and they're only an email away. Sometimes you can text them, and you can say, I'm in big trouble. What do I do? You could do it on your lunch hour. They'll tell you what to do. And if it's over your head, if they work for the same company, or maybe if they don't, you could still say, look, I know someone who can help you. I know who can pick up where we left off. You develop this relationship. I said the best thing for you right now is to go see the certified hand therapist down the road because they are going to make you this awesome piece of orthotic, and it's going to really help you feel better. And you don't want me making that orthotic because I don't know how. But we're going to figure it out, and they're going to help you. So don't think for 1 second I minimize, because I need you guys. I need you bad because I don't know how to do all that stuff. I can get you by, and we can march forward, but I need you guys. But please never forget that you are a master of life. You're a life coach. That you might be all this person has. You might be the only person talking to this person. You might be the only positive influence in this person's life. You've been mastering occupations for a long time. Ever since you graduated high school and started to do this, you've been mastering what it means to engage in occupation. You're really good at it. You're a professional. And you can really help people start to engage in their occupations too, no matter what. You could be the reason that someone gets better. And you could be the best clinician that they've ever met in their whole life. Better than any doctor they've ever met. Better than any psychotherapist or school counselor or anybody. You could be the best clinician they've ever met in their whole life because you didn't turn them away the first day and you said, we're going to figure this out together. So thank you. That is called being a generalist and promoting and doing the most good. You can reach out to me anytime if you want to. You can grab me today, or you can email me at the email address there. And so I don't know how long that took, but I think I got done early. The time is yours. And thank you.
All right, before you get up, we've got a little bit more. So I want to start off by thanking Sam for what a wonderful performance, or presentation. It's always a pleasure having him speak at our conference. So before moving forward with our breakout sessions, we would like to note a few things. In your folder, you can find several important documents for all the events today. So there is a schedule. You can find a schedule in there. On the schedule, you can find the times, locations, and topics during each round of breakout sessions, as well as the time for lunch.
You'll then find the poster presentation attendance sheet that displays the different topic areas of our second-year research projects and will be used to track your attendance at the poster sessions for further CEUs. On this document, you'll find a QR code where you can vote for your favorite presentation, and the research group with the highest number of votes will receive a reward. If you have any questions regarding this document, any of the student researchers should be able to assist you. There's also been a slight change to the schedule. The alumni mix and mingle is now at Pierce Road Bar and Grill. And so for the seminar rooms, they are upstairs across the hall. There's also coffee outside, coffee and beverages for anyone who would like.
All right. Next, we would like to draw from the raffle for everyone who donated their polos for the polo drive. Does someone have the tickets? Oh, it's right here. Never mind. All right. Can everyone hear me? All right. It is 034005. They might be in the room that we're streaming to, so I'll save this. But if anyone, whoever won, get in contact with me and you'll get a Target gift card. And then for CEU calculations for all clinicians, your CEUs will be calculated as soon as possible, and you'll be emailed a certificate with the number of CEUs that you received based on your attendance. But we would like to note that not everyone has paid for the conference, so until you pay for it, you will not receive your CEUs.
All right, and if you have any other questions or concerns, please feel free to contact us.
All right.
That's
That's good enough.